So the talk today is about how we can circumvent problematic vessels or vessels that are extremely tortuous, which technically makes it difficult for us to reach the target site which we plan to treat. So what are the common conditions which present with difficulties? It could be a tortuous iliac artery, a dilated tortuous aortic arch, as we've seen in the elderly and in patients with uncontrolled hypertension. It can be the acute takeoff of arch vessels, tortuous neck vessels with prominent loops, especially around the tonsils. I will also talk about how we can cross a large intracranial aneurysm, especially when you want to place a stent or a flow diverter across. And then finally, also how we could approach when we come from the arm either through the brachial or through the radial approach. So what are the problems that are associated with tortuous vessel? One, you will find it very difficult to actually take up your guiding sheath or your guiding catheter. Whenever you push a catheter or a wire or a device, you find they don't push, they tend to buckle inside the curve. More the loops, less the toggability of your wires, and thus wires will have no response, or they may have no response and a sudden movement of the microcatheter over the wire. Then invariably it means longer procedure times, and longer procedure times means more complications. So to summarize, it is a pain, and there's no doubt about that. And unless you know how to circumvent this problem, you're going to end up in a situation which can be frustrating. You will have mental fatigue, which again can be a reason you have complications. So let's start from the iliac artery. Now, when the iliac artery is extremely tortuous, you may not know it till you find that your J wire is not going up. In such a situation, ensure that you do not blindly push your J wire. You will end up in dissecting the vessel, and you may have to go and access the opposite side, and you may have the same problem unless you understand what's going on. So the best thing would be is to take the wire to the point it goes without force, then take a dilator over it, just so that you are in the distal external iliac. And if you see there is free flow, take a good injection, make a roadmap, and then try to cross the tortuosity. The best combination is used to angle catheter like a Bernstein, an angle thermo wire, and torque your way up into the outer. So once you reach that position, it's pretty straightforward. You take your catheter up. As soon as you take out your wire, you'll find that the tortuosity comes back into the iliac vessel, and you're going to face the same problem that I talked about before. And that is the problem of inability to torque or push the catheter. So the best thing for you now is to put an extra stiff wire in the catheter and take out the catheter and replace it with a long sheath. I hope you got the idea. It is now much easier to work because there is no tortuosity in the vessel. You replace the tortuous vessel now with a long sheath. So remember, a long sheath is very useful in a tortuous vessel. You can have a sheath that's long as 70 centimeters if you're working in the arch vessels. And once you got that long sheath, you'll realize how easy it is to torque your catheter and your wire and to access the vessels of the neck. So the common sheets that are available are sheets made by Arrow and Cook. These are the most popular sheets. Of course, Thermo has got a sheet called the Destination. That's also an excellent sheet. So it is your choice, but the fact remains that long sheaths can make a big difference in a tortuous iliac. Now, once you reach the arch, you have to understand how to hook the vessel's neck. Often I find many people trying to hook vessels in the anterior posterior position. Now, when the aorta is unfolded, what's going to happen is this. You will have the vessels overlapping each other, and you may not be able to see the origin of the vessels, making it challenging. Now, as you move to the left anterior oblique, the vessels are profiled better, and once your vessels are profiled better, accessing the vessels become more easy. And this becomes of paramount importance when you're working in a bovine arch, and also when the arch is a type 3 arch where the innominate artery will be coming much lower than the subclavian. So trying to make you understand this again, don't do it in the AP, go to the left anterior oblique. Now have a look at this. Now, as you see this, you can understand this is how a left anterior oblique looks, which profiles the vessel much better. Let's understand a little bit about the types of aortic arches. So we have a type 1, which is the typical aortic arch that you see in a young individual less than 40 years, unless he's an hypertensive. But as a patient gets older, and in addition, if he's a hypertensive, the arch elongates. And once the arch elongates, the whole vessel anatomy starts changing. You can see the innominate now comes from a much lower position. The left carotid takes a very acute takeoff, and it gets worse when it's a bovine arch, making it very difficult to access these vessels. And one has to have a strategy. Thus, there are many catheters available, but having said, the catheter that I would choose in the most difficult arches is a Siemens 1 or a Siemens 2. There's hardly an arch that you cannot access or a neck vessel that you cannot access with these catheters. But today we also have a wonderful access coming through the radial artery, which I will be talking a little later. If it's a type 1 arch, it's technically very easy. Take a catheter that has got a small bend, something like a vertebral catheter or a Bernstein, hook the ostium of the vessel, take a Terumo wire across it, torque and push the catheter. Remember, don't try to push it without torquing. Once you torque the catheter, mostly in the clockwise direction or sometimes in the anti-clockwise, you will actually see the catheter driving up the wire. I hope you're getting this point. You will see the catheter driving up the wire, and thus you will get into a stable position. But it's very easy. So when you have an arch of this sort, the best catheter to take is the Siemens 1 or the 2. So what you would do is you would take it into the ascending aorta or at the junction between the arch and the descending aorta, and you'll make the curve. Once you've got the curve, as you inject contrast gently, you will hook the ostium and pull the catheter and you'll enter the vessel. The same is done for the innominate as well as for the subclavian artery, and individually you can hook these vessels. Now, when you want to enter into the internal carotid artery through the SIM1, take an angled exchange Terumo wire into the external carotid artery. Obviously, it means that you would have created a roadmap. Once you've done that, you will take a catheter across, pull out the wire, replace it with an extra stiff wire, pull out the catheter, take a long sheath now over the extra stiff wire, and now you are ready to do the procedure. Technically, you can just about introduce a little bit of the soft end of the extra stiff if you want carefully, and then you can push your sheath a little higher and you are in stable position. Now the Siemens 1 and 2 has its own set of problems. So let me explain these problems to you. When you take an angle pterymo wire into the external carotid artery and you try to push on the Simmons, if the curve is very acute, it will only fall down. It won't go up. If the curve is not too bad, by keeping the wire distal and togging the Sim1, you might be able to take the Sim1 up, but it may not always happen. So what do you do next? Thus, a simpler approach in this is take an angle exchange pterymo right up, pull off the Simmons, take a catheter with a simpler curve. After you have straightened the wire a bit, there will always be a loop where the vessel takes off from the arch. Then now take the simple catheter. One of the best catheters that tracks in a difficult anatomy is the glide cath from Terumo. The glide cath from Terumo. Now once you've taken that up, you've got a much better position. Now what do? Take an extra stiff wire or a medium support wire across. Now when you take an extra stiff wire, if this angle is very tight, you will have another problem. This is what happens. Just as soon as the soft end crosses and the extra stiff component comes across, it will buckle the catheter into the ascending aorta. If this happens, you must be ready with a medium support wire like a Roadrunner wire from Cook. So this will go, and once this goes, you can now take the long sheath which is already positioned inside the body. So it's a 70 centimeter long sheath. Your catheter is 100 centimeters. You got a length of 30 centimeters beyond it. And now over this combination, that means you got a medium support wire, the catheter, and then the long sheath. You can try to push it and it may go. But at times you can still have a problem when it hitches on the edge like this. Do not push many times, because if you push roughly, you will throw plaques up the brain and you can have a stroke. So if this happens, you got to change your strategy. Take the catheter out and take the sheath along with the dilator. Now the step that was there before is no longer present, and once your dilator is gone into the proximal common carotid artery, disconnect the dilator and push the sheath over the dilator this way. You understood that? So don't take the dilator distally, it can injure. There's another technique called the remote axis, where you try to cannulate the vessels from the ascending aorta, and once your wire has gone in, you can try to pull the catheter up and you can achieve it. So thus there are many ways that you can reach it even in a difficult aorta, and if it doesn't work, I'll talk about other techniques that you have, like a direct puncture and coming from the arm. Now I want to talk about another simple mistake made by a lot of people. You want to enter the carotid artery, but you keep entering the subclavian on the right side. Now this again is a problem when you're trying to do this procedure in the AP view. So in the AP view, the origin of both the vessels overlap each other. So now you take a right anterior oblique view so that the vessels are separated well, and you can enter the vessel because you can see better. So here it is. You have an AP view, you've got an LAO view. In both of them, the carotid and the subclavian are not separated. But see, when you come to a right anterior oblique, it is beautifully brought out. And this is the angle at which you should take the roadmap. And very often you find that all you needed was the right view, rather than trying to push things and getting irritable and getting upset and changing wires. Seriously, most of the time, the mistake we make is not having a right view in place. Now let's keep going further and understand the type 3 aortic arch and a technique that we're going to describe, which can be very, very useful. Okay, Now, this I want to make you understand is something that we have been doing for some time. We find it extremely useful and we call it as a distal anchor technique, a distal anchor technique. So this is a vessel, there's an aneurysm out here and we want to treat. But the problem out here is, can you see the carotid is taking its takeoff at a position that is really low. And now if I want to take a long sheath across, I find it difficult because it is difficult to cannulate this vessel. So how do I go about having a long sheath in position and then trying to cannulate it with an angle catheter? Okay, so this is what we throw. It's a type 3 out there, a difficult anatomy, and how do we do it? So the first thing is we know we can enter the innominate easily. We do that. But the problem is the SIM1 or the SIM2 will invariably enter only into the subclavian artery. So let it enter the subclavian artery. And now what you do, take the ball distally, and what we would do is today is to replace it with an 1/8 exchange length extra stiff wire. A 1/8 extra stiff exchange link wire. The wire that we choose is called V18. It's made by Boston Scientific. So now I've got a situation. I've got a wire running from the groin all the way distally into the brachial artery. Now I take a long sheath. The long sheath, I said, is already there inside. I just push it up. So now what I've achieved, I have got the long sheath in a good position at the base. And I know that the long sheath cannot come out because the wire is distally anchored. The wire is distally anchored. Now I take a catheter and then take another wire into the carotid. It's much easier because I got a sheath. I can take injections. It's much more stable. I can torque this wire inside it. It won't keep falling because obviously the long sheath gives support. And the long sheath now will not fall into the outer because I have got this extra stiff wire all the way into the brachial artery. So that's why we call it as a distal axis, or we call it as a distal anchor technique. So I've got an anchor at another point which is going to now help this. It's very similar to a buddy wire, but the buddy wire is put in the same vessel. Here you're putting on another vessel. Okay. Now when I'm very deep into this, in a very secure place, I can actually move the whole device up. Okay, that's technically not difficult. What we'd have done in this case is we'd have taken that catheter. Now I've got the wire. I would have taken a diagnostic catheter over that, exchange it for an extra stiff wire. Now I'm very secure and I take this out. I hope you understood the step. Take a 1/8 extra stiff wire deep into the subclavian artery. Keep the sheath at the bottom. Use a wire like an angle Teramo wire and now go distally in the carotid and the external carotid. Take a glide cat distally into the internal carotid, exchange it for an extra stiff wire, pull out the V18 wire, and now you can push that sheath into this, right? It always works. There's an example. I'm showing you the same thing, the difficult arch. Look at that loop. Really, really difficult to enter. So the long sheath is inside. And we have got the SIM1. The wire is gone really distally into the brachial artery on this side. Now, with this combination, I am going to enter the carotid artery. Can you see the wire? It's gone up the carotid. It's easy to understand. It cannot slip out. It's impossible. And as I told you, in this case, you don't even need a V18 because you're just going to take a 4 French diagnostic. You can keep a regular extra stiff wire here. Then you can take your diagnostic catheter through this. If it's a 4 French on a 7 French long sheath, obviously will not have a problem. But if you're working on a 6 French, you'll have to use a 1/8 extra stiff wire. And you can understand it's very easy now to take the diagnostic catheter over the other wire, right? So it's challenging. So here's the diagnostic catheter all the way up. Now I will replace that with an extra stiff wire. Pull out this wire. Once I pull this wire out, I'm going to push the long sheath up, and it is not a problem at all. I hope you understood this. Technically not at all challenging, provided you understand this concept of keeping a wire distally anchored and then taking the catheter and then taking the wire into the target vessel. And then after you're secured with the diagnostic catheter, exchange it for an extra stiff wire. Now the extra stiff wire is there, you've got a catheter there, pull out the catheter from the subclavian, push your sheath up, and you are in target position. And we have used it n number of times, always has worked, never has there been a problem. So you can see how we are taking the long sheath higher. We got this up here, and we could completely obviate the need of any direct puncture. We could, through this, you can easily take a DAC-like catheter and complete your procedure, a neuron or a Fargo max, any of these, okay? It's your choice. And this was the lesion we treated. The problem was we had a stenosis coming all the way here. Now imagine in such a situation, again, you'll have the same problem. You want to put a stent, you want to keep a long sheath down here. If you do not have an anchor on the other side, it's very possible that this long sheath will out. Have a look at what we're talking. Here you got, this is the 1/8 wire. In this case, we are going to keep the sheath here and do all the work. So, and you got a second wire going up here. Now, keeping that position, keeping the wire always in the brachial artery, we could complete the stenting in a very secure way with nothing moving at all. I hope you've understood it. I hope you can understand how easily you can do it. Let's come a little higher. What happens when you get very tight ACL loops? Today, these are not difficult thanks to extremely good devices. So one thing before you start, you have your long sheet down here. Use a nice long sheath. I would prefer a Cook 7 French because it's rugged. We just want to keep it in the bottom. You take the Neuromax. The problem is if the Neuromax doesn't go all the way up, you lose length. I would keep the long sheath here and through that take a distal access catheter like the Navion. I find the Navion very trackable. Otherwise, especially when you want to use two devices, otherwise devices like the Cat 5 or the Cat 6 or the Sophia is amazing, but of course Sophia is made more for aspiration, so it's longer. So we get a whole lot of catheters, but my choice in a situation like this today would be Navion. So here it is. You see we have circumvented all those loops. We are right here on the top, very easy, without much effort at all, right? So to do that, the steps are this. First, you go to the point where the vessel is reasonably straight. You got a 5 French long sheath or a Neuromax out there. You take a Neuron or 6F Navion or a Cat 6 if you're taking a single device, Cat 5 if it is a single device. And remember that these will go over a 2.7 microcatheter. The Navion will go over the 2.7 microcatheter, and so also the Cat 5 or the Cat 6. But before you do that, prime the vessel with nimodipine. You will have to do, otherwise you'll get into severe trouble. Make sure that you prime the vessel with 1 milligram of nimodipine, diluted in 50 ml of saline, and then inject that slowly over 10 minutes. Now, once you keep a watch on the blood pressure, you can have a drop in the PP. And once you have done that, you'll take this microcatheter, which is a 2.7 microcatheter with the wire of your choice, and over that you'll take the distal access catheter. Like I said, my choice for very tortuous anatomy is actually a Navion, which I like a lot, but you could also try with the Fargo Max, Neuron. But I've seen that for if it's really bad, if it's a 360-degree loop, Navion works the best. So after that, you're out and you got access and you can do it. Now, when you take these devices, sometimes they will get stuck at the ophthalmic artery. So I know that Stryker is coming with a beautiful device, which is like a dilator that goes in and prevents this step. Otherwise, remember, the 2.7 catheter is necessary for this because that will take the step out and you will be able to cross. Otherwise, you will not be able to cross. Now, what happens that you are in a situation like this? This is a type A dissection and the patient has got a problem with the brain. So today, for every other reason, we can come from the arm. I'll talk about that, or the techniques I talk you can reach. But in this, there is no way you can reach either from arm or the leg, and then you can do a direct carotid puncture. It's like you bypass, land on the target. So how do you do it? So under ultrasound guidance, or with a diagnostic catheter, if you can enter, keep injecting contrast softly, but I think ultrasound is the best. Puncture as low as possible in the carotid, and with the needle inject contrast. Take a road map, take a wire so that you enter into the external carotid. That's why your puncture has to be low. Once the wire is deep, take your sheath inside. You can take only 50% of the sheath. Now, once you've taken the sheath just below the bifurcation, take a sterile tape and tape it, or take a tagaderm and tape it completely to the neck, because the sheath should not kick out when you do a procedure. Once you've done that, it's simple. Take out the wire, change the wire to the right direction, and take your device. Whether you want to take a neuron or a navion or just a guiding catheter, whatever happens, you can take it up. Once you're taking that to the target site, tape that also up to the skin, because you understand when you're now going to work quite far off, you will not see what's happening in the neck. Things will kick out, and you will find you have a huge hematoma in the neck. So remember, in the neck, everything has to be taped, everything has to be fixed, so nothing moves. So once you've got that, pretty straightforward. Like in this patient, had a mycotic aneurysm in the distal ACA. So what did we do? It's showing we punctured, we carotid, we enter into the target vessel, we embolized it and cured the patient. So just to tell you that it can be difficult, you can cross it. What happens in a situation like this? There's no femoral artery, there's no access at all. Then you can try to come from the arm. When you come from the arm, whether you use a radial or a brachial approach, the best catheter again to handle this problem is a Siemens 2, not a Siemens 1, it's a Siemens 2, because the Siemens 1 will be will not hook all the vessels. So this is how you do it. Your Siemens 1 is here, you pull it, it enters into the left carotid, bring it, rotate it, and you enter into the right carotid artery. Have you got that? Same thing can be even to enter the vertebral artery on the left side. So these are cases, see, like a very, very tortuous anatomy, looks very coming from the arm. It's not a difficult challenge. For the vertebral arteries, it's excellent. For whether the right or the left, gives you phenomenal access, very good support, and you can come like this case, again come from the arm using the Siemens 1. Of course, it was the outer was not dilated, it was an occlusion. If it's a dilated outer, like I said, it is a Siemens 2 that you need. Carotid was successfully stented. Or coming from the opposite side, just look at that, very tortuous anatomy. Really come from the leg at all. So you come from the arm, you can see the procedure, pretty straightforward when you come from the arm, and you can treat it successfully. So the last topic we're going to talk today is how do you cross a giant aneurysm, or an aneurysm which is like 20 millimeters in the internal carotid artery. So you try to take the wire. There is no way the wire will go unless you do this. So you take your distal access catheter, like a neuron or a navion or a cat 5 or a cat 6 or whatever down here. Take your microcatheter to the mouth of the aneurysm, push your wire. As you push the wire will exit out, but with a big loop. Now, obviously, you cannot have the loop because here you're going to put a flow diverter, and the flow diverter has to be across the neck, not looped. Show you a very simple technique which was shown to me by Dr. Dodi. Before that, we used a much more complicated technique. Now you take your micro and let it be a soft micro, the softer the better. So what I normally use would be a 17 microcatheter, which I use for coiling, and take it as distal as possible. Once you're done that, pull the wire out. That is the secret. If you keep the wire in and pull it, the loop will continue to be retained and the tip will move. If you have a soft catheter like this, without the wire inside, now as you pull on the catheter, it will straighten. So fill this microcatheter with contrast and pull back. And as you pull back, it straightens easily without the tip moving at all. So it's good to have it very distal, because by the time you see the tip moving, you know it's straight. Also remember, sometimes the whole thing will fall back, and that's why I said to fill it up with contrast so you can actually see. Then it's straightforward. You can just cross, like in this case, put a flow diverter across it and do the treatment. So this was successfully treated. So you understand, this is a very, very easy way to cross a difficult aneurysm where you may have to struggle for hours, but if you know the technique, it doesn't take more than a few minutes. And remember this, is a very, very famous picture which says, never give up. But remember, when you're doing especially neurointervention, never ever be stupid as not to give up. There is a time where you realize you're going through fatigue, things are not looking good, the catheters are not moving, the wires are not moving. Learn to give up. The most important person in the cath lab is not your ego, is not how you impress your juniors or your seniors or your nurses. Even if she's the prettiest thing over there, the most important person out there is your patient. They have given their lives to you, they trust their lives to you, and if you think things are not going, come out. Maybe you can think of a better strategy, or maybe you can send that patient for surgery. Many of these techniques are not described in books. It's something that we have learned over the years. And I hope that you have enjoyed this talk, and I hope you find it useful as you do cases. Do write a feedback, because that's what motivates us to put these techniques for you in YouTube that you can learn from all our experiences. Thank you so much.